Hello, my name is Drew Lecure, and today I'll be giving my presentation, or my final presentation, for Discourse 300 at UMKC. So please enjoy. All right, so this essay is about safety net facilities like Truman Medical Center and how they represent our nation's current best effort in regards to mitigating healthcare disparities and providing care for those that would otherwise lack the ability to seek it and achieve it. In this essay, I get a little bit more of a personalized look at some of the systemic issues that are reflected back in my original or my first assignment, which spoke about more of the systemic issues, those being in healthcare, those being race and socioeconomic status, health literacy, and distribution of health resources. However, this presentation gets a more personalized look at it from various interviews I conducted with 3 different patients at Truman Medical Center. And kind of how their experiences went and ways that they would improve the system as it exists today to provide the best level of care. So, like I said, this presentation was done through combining extensive peer-reviewed literature sources and then interviews I conducted. Just of note, these patients' true identities are protected through HIPAA, and so therefore I will be referring to them as pseudonyms I've assigned to them. Jose, Latanya, and John, respectively. For the sake of time today, I will be picking my strongest argument from the essay and presenting it to you in depth. If this presentation seems somewhat disjointed or you wish to learn more about it, I would recommend reading my full essay, which will be attached down in the discussion board below, just to get the full context and the full list of sources and whatnot. Okay, so to start off with, I will define the term safety net hospital or facility for those of you who are unfamiliar with the term. I will use a definition from the article, Health Reforms Hold Both Risks and Rewards for Safety Net Providers and Racially and Ethnically Diverse Patients. And that article was published in the Health Affairs Journal, Volume 30 by Dennis Androulis. The definition is as follows. Safety net institutions organize and deliver significant level of healthcare and other related services to uninsured, Medicaid, and other vulnerable patients, of which minorities, end quote, and of which minorities, homeless, immigrants, and those of the lowest socioeconomic status make up a large portion of those served. That's kind of what they meant through the usage of the term vulnerable patients. It serves those who need the service the most. So before I dive into the personalized perspective of the patient that experiences issues at Truman Medical Center, and just obviously Truman Medical Center is an example of a safety net institution, and that's the one that's found here in Kansas City, Missouri, and the one that I personally work at. So all of the patient perspectives have been drawn from that pool. So bears keeping in mind. At first, I would like to address just 2 of the primary arguments people have for not supporting universal healthcare in the United States and just kind of narrowing the gap between healthcare disparities. The first argument people tend to have is in regards to the establishment of meaningful universal healthcare is the perceived increase in financial burden associated with providing coverage for those that don't have coverage today as it stands. And it kind of makes sense if you think about it. Millions of people across the country don't have health insurance today, and if we provided healthcare insurance for them, they would then proceed to have more expenditures on healthcare and thus increase the cost of healthcare as a whole in our nation. However, I have a source here, or I have a study that I've read that will help dissuade you of that. Let's see. Okay, so however, a study conducted in 2003 in Taiwan was shown to debunk this line of thought. In 1995, Taiwan implemented their national health insurance, NHI, which is their form of universal healthcare. And in this longitudinal study, we were able to observe that the increased cost in healthcare, with the increased number of covered individuals under the new plan, did result in a slight uptick in the overall cost of healthcare, was more than covered in actually it showed a decrease in net expenditures due to a decrease in acute emergent situations where they need to be hospitalized, more preventative medicine as opposed to reactive medicine, which makes lots of good sense. A lot of the some of the worst admissions to a hospital you can have are for someone that has never taken the medications that they need or that they should have taken for years on end. And then they have much worse health consequences because they weren't able to get the upfront cheaper care that they could have received with just a small adjustment into how the system works. It's much more expensive to pay for someone in an emergency room than it is to give them their $4 lisinopril for each month for their uncontrolled hypertension. So something to think about. This evidence was pulled from the article, Does Universal Health Insurance Make Healthcare Unaffordable? Lessons from Taiwan. And that was written by Liu and Xiao in the Health Affairs Journal, volume 22, if you're interested. So like I said, better management of chronic conditions leads to less cases of emergent medical issues that need to be addressed in the emergency center, thus overall lowering the cost of medicine through preventative measures. The second argument people have for why we shouldn't, support universal health care in the U.S. is because it provides coverage for the illegal immigrants and the homeless of our nation, and people see this as an affront to taxpaying Americans. In regards to this complaint, there have been attempts in the past to restrict provisions, both federal and state, for services provided for undocumented immigrants. A study conducted by Colburn showed that two primary issues that arose from putting up barriers to these treatments of these individuals was, one, an increase in moral or ethical strain for the healthcare providers, and two, the increased risk of transmitting communicable diseases throughout a subsection of the population that you do not treat. And that makes good intuitive sense. If you think about it and you don't provide care for a large subsection of the population, i.e. the illegal immigrants, that subsection of the population could, contract or be a harbor for deadly communicable diseases that would then thus spread to the rest of the population, providing or creating a health concern for everyone. So by barring the treatment of some, you negatively impact the whole. So that's pretty self-explanatory. The first one, though, an increase in moral or ethical strain for the healthcare provider, takes a little bit more to think about, and especially if you haven't been exposed to the healthcare system, as I have as a medical student, and what I've observed here at Truman is that, people get into medicine to help people, overall. That's kind of what the general theme is for people wanting to go into medicine, is to provide the best level of care and comfort for the people we treat, to make them live the best lives that they're able to, and not barring, unforeseen illnesses and the things that we can do or that we can help with. So we all go into medicine to help people, and by putting up these stipulations as far as to who and who not to treat, you create an undue strain on the provider. As for each patient he or she interacts with, you have to look at, am I right in providing care, or is there some statute or legislative document somewhere that says that I should be avoiding treating these people. So those are two of the cited reasons for pushing back on any legislation that would prevent care for this segment of the population. So we've addressed the two primary concerns people have with establishing universal health care. So we'll kind of dive into a great reason for improving the system that we have today, in fact. One of the biggest disparities I have personally experienced as a medical student, like I said, going through my various clerkships and having been exposed to a wide variety of types of patients and learning about their social situations, is seen through their health literacy, or lack thereof, as it well may be. So in interviewing LaTanya, a 65-year-old African-American lady who presents to the clinic just with a recurrent complaint, and quote, she says, "I appreciate all the efforts you have given, but I keep trying to tell you why the plan isn't working, and no one seems to hear me." LaTanya described how the problem she had been trying to address for the last several visits was not being handled, and it seemed to be dismissed by the healthcare team she had worked with, and she'd worked with a number of them. She goes on to say, "I feel like you aren't getting what I'm saying, and I know I am not getting what you are saying." And that when she said that to me, I realized right away that the barrier to success and health outcomes was due directly to a lack of health literacy, and that is to say an understanding of the plan and understanding of the information that the doctors or the healthcare team have given to her She gave me the same information she'd given everyone else, but with the way I had imagined that office was and how, the busyness and the hecticness, and if you present a plan to a patient and, in your mind they should understand it, it's quite easy to dismiss them and, go on to the next patient. But in reality, the things you told Latanya to do for her patient or for her problem, despite the fact that she's more than willing to make these changes, is the barrier is where she doesn't the gap in understanding. She won't be able to do the things you tell her to do if it's not explained to her in a way that is meaningful to her. I mean, it has something to do with shared decision making and like how the system, as we're trying to build it from at least the medical student perspective, is a system in which you've got a shared decision making process where the patient is very active in the understanding of the goals we're trying to promote, and then by avoiding that or by not supporting shared decision making and the patient centered approach, you often will have these gaps in what's expected and what's performed, and that just provides worse health outcomes when it really shouldn't be that big of a deal. So I have an article that kind of talks a little bit more about that, and the article being called "Impact of Health Literacy on Socioeconomic and Racial Differences in Health in an Elderly Population." And in this source, the author describes how most members of the lowest socioeconomic status, which Latanya and a large portion of the patients here at Truman would fit into, have received less than a high school education, and now how this negatively impacts their health outcomes. Like I said, it's a huge portion of the patient base at Truman is just those of the urban environment, which didn't receive a whole lot of formal education through whatever reason, and how that negatively or impacts their ability to understand the plans that are put forth by the team. However, so understanding what Latanya's issue was, I was able to sit down and just by taking the extra few minutes, to let the patient ask her questions, and like to voice their understanding of the plan, I was able to mitigate a lot of the issues that she was having. And I actually followed her up next week, the week following this interview, and talked to her a little bit more, and this is what she had to say. Latanya says, "If people would just take the few minutes, just like you did last week, to explain and allow me to ask questions, then I would not have have come to the office again and again, and this all would have been taken care of." This is something I think all healthcare providers, not even just specifically limited to safety net facilities, but all providers need to strive to improve their patient physician interaction and be able to really get the truest sense of the situation by just listening and being, taking that few extra minutes, which is very hard in a very hectic, office that I've been exposed to. It's just important, whether it be a simple phone call later on or just taking those 5 minutes at the end of the appointment just to make sure your patient understands. I think it's one of the easiest ways to hugely impact the healthcare quality in safety net facilities as well as facilities throughout the nation. And that would just, it would narrow the gap that health literacy differences have on negative health outcomes here in America. So, thank you.